I think it's a really exciting time for the immune checkpoint inhibitors in triple-negative breast cancer, but I also think that we've got a lot more to learn. So far, we've got FDA approvals for both atezolizumab and pembrolizumab in the first-line metastatic setting in combination with chemotherapy. For atezolizumab, we saw very convincing data that adding atezolizumab to nab-paclitaxel offers benefit across a couple of variables to our triple-negative patients. However, confusingly, a similar trial, very little difference between the trials that used paclitaxel as opposed to nab-paclitaxel, did not show that same benefit. So was it the steroids or was there something else? Additionally, analysis of the atezolizumab trial shows that the benefit is really maintained only in those who test positive for PD-L1 in the tumor-associated lymphocytes, which is around 40% of those enrolled, and not in those who did not have tumor expression of PD-L1 in their surrounding lymphocytes. For pembrolizumab, the trial that led to its approval, you had your choice of either a taxane, and you could choose nab-paclitaxel or paclitaxel, or a combination of carbo and Gemzar. And to date, the data we've seen shows that there is benefit, again, only in the PD-L1 population, with all of those chemo agents, although the number of patients treated with paclitaxel per se was small and hasn't been well sorted out. So benefit in the metastatic setting, how we now use the sacituzumab govitecan, which is in its own way in immunotherapy. It's an antibody drug conjugate that's got good activity in triple negative. We've got to sort out all of that. Now, fast forward to the neoadjuvant setting, where we've had positive trials for atezolizumab and pembrolizumab with respect to pathologic complete response rate. And we have some confusing information there, such as doesn't matter what the PD-L1 status is, and it looks like PD-L1 expression is much more common in the primary tumor setting, much higher rates of PD-L1 positivity. So that's a little confusing. We don't yet have any long-term data as to whether that really translates into a disease-free or overall survival benefit. So we're not ready to routinely add immune checkpoint inhibitors to preoperative chemotherapy in triple negative. And of course, SWOG has a very interesting trial ongoing looking at triple negative breast cancer that gets standard chemotherapy, and then there's residual disease seen at the time of surgery, and patients are randomized to single agent pembrolizumab or not in those high-risk patients. So we're awaiting the results of interesting studies like that as well. I think we've really got to sort out how to do PD-L1 testing because they're very different assays, even looking at different cell types between pembro and atezo. I think we have to decide, is that testing the best predictor of who's going to benefit? It's kind of fallen apart in the early stage setting as being a predictor. Are there other predictors of who benefits from these agents or who doesn't respond at all from these agents? We've got a lot of work to do there because these agents are not without their side effects and their toxicities. And we really want to be giving these drugs to those who are going to benefit and not give them to those who won't. So lots more work to go there, but exciting times in immunotherapy in triple negative breast cancer.